The way that I got into ultrasound is I was sitting at our grand rounds, and I was sitting next to our radiologist because we invited multidisciplinary grand rounds, and he was telling me how he was just looking at his meniscus tear on an ultrasound, and I was like, this guy's crazy, like meniscus, you can't look at your meniscus with an ultrasound. And then he was telling me about, yeah, he started doing it on his shoulder, and then he got into that, and I'm like, you can't look at a shoulder with an ultrasound, it's for babies, you know, I didn't really understand. And so I started looking into it, and it just seems archaic, you know, as you're coming up and everything's MRI. And as I started to read the literature, I realized how good ultrasounds are, and how easy they were to perform. And so when I got to town, it was a big part of my practice, and I did a little bit of research in it in my training, and it just kind of become a pet project of mine. As far as disclosures with this, I don't have any disclosures regarding this talk, but I am looking for them. I've been talking with Sonosite for a long time about trying to pay me to do this, but they don't want to. I don't think I'm good enough. But if you do go into Sonosite, first of all, Sonosite donates all this time to us and all this equipment for us. We aren't paying for it in any way. They aren't asking for anything from us, but they are a great sponsor to education, okay? I've probably been a part of getting maybe 15 of these throughout my career, whether it was in my fellowship training, to get in for education. Again, I'm not a paid consultant with them, but if I were buying an ultrasound today, it would be Sonosite because of the service. You get young ladies like Karen over here. Is Andrea here? Andrea, like these people are awesome. They will come to your office, they will walk you through it. No matter how many times I said, can you tell me how to do this again? And I forgot how to do it. They'll come and they'll do it. If there's a problem with your machine, your probe, whatever it is, they have a really good service program. They'll overnight stuff to you and take care of you. And it's a really good device as well. So that's my plug on that. All right, ultrasound. We'll go over the basic terms and techniques of the ultrasound. We'll talk about the benefits and limitations. We'll go over a 13-point shoulder exam that I learned from Don Buford, who's in Texas. And then we'll get you guys some time to do some hand-on practice as well. So the basics, okay, you need two pieces in order to do an ultrasound. You need a device, you need your ultrasound base, and you need a probe. Okay, that's the two most basic items you need. If you're going to invest in this, whether it be a $20,000 device or a $15,000 refurbished one or a $80,000 Mac Daddy one, you want to protect that device, so I do recommend a cart, okay? So if you're going to do something like this and you're going to invest in it, spend the extra money on getting a cart to transport it from room to room, okay? You'll need some gel, obviously, and then in order to get paid for this, you have to have some way to save an image, one single image in case you get audited, that you can say, look, I did this, here's what it was, and you need to create a note that says that I've recorded my findings, this is what it was. You can either do a printer and stick it in your chart. If you have DICOM, you can push it to your EMR. All of those things are options. Now, you can get really crazy and wild and do all kinds of stuff with it. Those are the basics that you need and that I'd recommend. When you look at the knobs, it can get very confusing. And one of the good things about Sonosite is they've dumbed it down for orthopedic surgeons. So if we can figure it out, you guys can figure it out. If you start getting into like the cardiology ones with all the buttons and wheels and whistles, it can get crazy. There's basically three knobs that I use. One is select. So if I'm trying to pick something, I use that. Same with freeze, okay? The save button as well, the saves are over here. So you gotta be able to select it, save it, and freeze it. Okay, those are the three main. And then you want gain, some form of gain. Auto gain is usually what I hit. Gain is just kind of dialing in the brightness and where you want it to hit. Now you can get very detailed in all these. Your girls, or sorry, I messed up. Your staff, I apologize. Your staff can program all the information in that you need as far as their demographics and all that kind of stuff. You don't ever have to touch that stuff. So how does it work? So your base creates an electrical signal. The electrical signal goes to your probe, which creates a sound wave. That sound wave then travels through your tissue and then bounces off that tissue and back to the probe. The probe then takes that image, or that wavelength, and it then brings it back to the computer, and it basically interprets based on how much signal is coming back, what you're dealing with, okay? When the tissues bounce off of softer tissues, you're gonna get less bounce back. When you have a harder tissue, you're going to get more bounce back, so that's going to be brighter. So the more dense that material is, and the more perpendicular your probe is, the more refraction you're going to get back. So it's very important that you understand the orientation of your probe. So if your probe is up and down against a flat surface, you're going to get almost 100% reverberation. You're going to get a really good sound wave. If you turn your hand to the side a little bit, it's going to bounce off, and some of those waves are going to go the other direction, and they're not going to come back towards your probe. Similarly, if you're doing a curved tissue and you're on that thing, even if you're going straight on, when you move over, you have to go around the curved tissue, okay? So it's important to kind of have in your mind's eye what tissue you're examining of how to do that, okay? Terms that you need to know. The frequency is important. The frequency is basically the size and wavelength of and measured in megahertz of what is being emitted from your probe, okay? The higher the frequency, the higher the image quality, but the less dense penetration, okay? The lower the frequency, the lower the quality image, but the deeper the penetration, okay? So if you're looking at, the volar forearm and you're looking at tendons in the volar forearm, you want a very high frequency probe to get very high good definition in those superficial tissues. If you're looking at the hip or the belly, you want something that's going to have a lower frequency wave that's going to bounce deeper into the hip and give you a better or better bounce back, because those higher frequency waves won't penetrate as deeply, okay? The next thing you need to know is echogenicity, and this is just kind of a descriptive term when you're discussing with another person about an ultrasound. So hyperechoic is basically very brightly dense tissue. That's going to be calcium, bone, hardware, those types of things. Hypoechoic are going to have less echogenicity, meaning they're less bright or dark, like air or gas, okay? So if you were to look at this shoulder, there's a humerus down here somewhere. This is looking at the supraspinatus tendon, and this patient has calcific tendinitis. So as you're looking down through that shoulder, you see the hyperechoic deltoid fascia. You see the deltoid muscle, which is hypoechoic to the hyperechoic fascia. Then you're going to see a hyperechoic or more dense calcium phosphate, and then you're not going to see anything underneath that because the calcium deflects all those waves back, so you get a shadow beneath your calcium, okay? So if you're trying to look at a rotator cuff underneath a calcific lesion, you're never going to get there because the calcium bounces it all back. Same with bone. You're going to get the same kind of thing. If that calcium wasn't there, that signal would basically end at your bone, okay? That all make sense? I haven't messed up any of my terms, have I? All right. So when you look at, last slide of terms. Longitudinal means you're basically examining the length of the anatomy being examined, and then transverse is through the short axis. So you have the long axis, which is the length of it, transverse is the short axis, and those are the two descriptions that you need to describe your material or your tissue. And then anisotropy, this is the biggest risk, I guess you could say, to using an ultrasound. So ultrasounds are really good, but they're completely dependent on the person doing them, which is why I don't farm it out to my techs or my PA. I want to have it in my hands because I'm making medical decisions based on that. Anisotropy is basically where you're imaging a normal tissue, but you're thinking it's abnormal, okay? And that generally occurs because your probe is at an angle and you're bouncing off at the wrong angle, and you're looking at tissue that's normal, but it's bouncing back to you looking abnormal because it's not hyperechoic or doesn't have normal orientation because you're not imaging it properly. So whenever you image something and you think you have an injury, go back and forth over it in each direction and make sure that it's truly an injury on multiple planes. So if you can only see that injury in one plane, and you turn it the other direction, it's not likely injured, because if it's torn or there's fluid there, it should be there in all forms. It's a three-dimensional structure, right? So anisotropy, this is a good example of that. It doesn't project real well on the screen, but this is your greater tuberosity, this is your humeral head, and you have your supraspinatus tendon running on top, okay? Now what we should see is nice linear collagen tissue, and on my screen up top, you can actually see there's a black area here that looks like, to me, like could be a void of supraspinatus tendon, but it's not. It's the angle that this probe is coming in. So when I change my angle, I can see these deeper tissues, then it's normal. So that's anisotropy. You don't want to call something abnormal when it is in fact normal. When you hold the probe, you want to make sure, like anything we do when we're doing procedures, you want to hold the probe that you can manipulate it correctly, okay? And most importantly, you want to be based on something. You want to have your hand stable. There's nothing that we do in the operating room, there's nothing that we do with a needle, there's nothing that we do with an ultrasound where we're not braced on something. Even when we operate sometimes, you'll have multiple hands in the field. I'll balance on my assistant's hand sometimes to ground myself to be more stable. You should do that for injections, for procedures, and for ultrasounds. You don't want to have it like I call this the monkey grip. Every once in a while I'll get a fellow or a resident that holds it like a monkey. And you can't control things. You can't have good accuracy if you're holding it like a monkey. Use your thumbs, base the ulnar surface of your hand on whatever you're doing, and then go from there. Benefits of the ultrasound, immediate results for you and the patient, and this cannot be overstated. When I started my practice, I had patients that I was the only guy in my small group that did this type of stuff, and right across the street from me was a giant multi-specialty group with lots of hungry orthopedic surgeons. And so if I was brand new to town and I sent that patient out for an MRI and expected them to come back, from the 2 weeks it took them to get their MRI and come back, they would talk to their friend who said, oh, I saw this doctor, and they'd end up going to see that doctor on a second opinion, and I'd never see him again. That's one problem. The second problem is that turnaround time. That patient is waiting now 2 weeks to go to the MRI, get it, waiting on the report, the anxiety is building. When you take this ultrasound and you put that on their shoulder, their knee, their ankle, whatever you're examining, and they walk out with a diagnosis, they're happy. You're happy. It's a billable procedure, so it can make you money in your office if you become proficient at it and it doesn't slow you down, and it's very important in that way. When you look at patient satisfactions, every study that's ever been done, when patients get ultrasounds, they're happier. You're spending time with them, you're touching them. Those are the two things that patients want. Touch them on the shoulder while you're examining it, spend a little more time with them and discuss it. They're happier when they leave your office. You can use it on the entire body. There's not a lot of things that you can say that you can do that, and you can do that at time 0. The ultrasound has really no contraindications. So how many patients do we have every day that come in that have had a prior rotator cuff repair, they have metal anchors, or they've had a total shoulder or a replacement or reverse replacement, and when you go to put your ultrasound on there, you can actually look at it. Whereas if you get an MRI, you get all this scatter and there's all this artifact, you really can't get much out of it. Cost is obviously an issue. Ultrasound is orders of magnitude cheaper than MRI or CT scan, especially with a contrasted CT scan. So ultrasound is significantly cheaper. All my patients, it seems, are claustrophobic. Seems like all of them have a pacemaker or a spinal stimulator. I didn't know they had this. I had a lady yesterday who had a bladder stimulator. I didn't even know that was a thing. So patients that are unable to have MRIs, okay? If you can't have an MRI, you can have an ultrasound. There's no contraindications to ultrasound. You can do image-guided injections. So if you're that person that's not real confident about doing your injections, when you're watching the needle go into the position that you want it to be in, you're gonna be a lot more comfortable knowing that that's where you want it to be for the right reasons and not in the wrong tissues. Dynamic exams. This helps me because sometimes I'll go back and look at my ultrasounds prior to surgery, and sometimes I'm like, where was that tear? What did it look like? I'm not really in the same spot. When you're doing it live, it means a lot more to you. So as you're looking at it live and you're moving and the patient's moving, you get a lot more out of that dynamic exam. There's no radiation whatsoever, so there's, again, no contraindications. How many of you guys cover sports? You can use it for sideline sports. You can diagnose fractures. You can look at acute swelling or acute tendon ruptures with it. And again, it's a billable procedure, so once you become proficient in it, it will make money for you. Limitations, intra-articular anatomy. You cannot see the superior labrum. You cannot see the anterior labrum. You cannot see much cartilage. You cannot see the biceps anchor. The only really area within the joint that you can see is the posterior labrum, which we'll look at when we do our exam. The other negative to this is if you're doing multiple spots. So if you're doing hand and elbow and you're doing shoulder and you're doing hip, you need multiple probes for that. Now the HFL 50 is pretty versatile. You can get most of those exams with one probe, but if you're really going to be doing this a lot, it can get costly with the probes. Those are the most expensive part. It'll definitely slow down your clinic times in the beginning, so once you get proficient in this, it really doesn't, but in the beginning it definitely will, and it's completely dependent on examiner experience. So the more you do, the better you're gonna be. When I got my first ultrasound, I took it home, and anybody that walked in my door, they got examined. I'm like, let me look at your shoulder, and I went over everybody, and basically every patient that came into my office, I examined all their shoulders. I didn't charge them for that, but it gave me that base of what I needed to learn. And people who had pathology, who had an MRI, that was like the prime time to do it. So I would examine them, then I'd look at their MRI, and then I'd examine them again. And then those pictures started to make sense in my mind, my hands started to get comfortable with what I was looking at, and then I started to make decisions to the point that I don't do MRI 99% of the time. I do an ultrasound on the shoulder, I diagnose the problem, and we move on. And I'm comfortable that, booking them for surgery and all that kind of stuff with that ultrasound. So to the exam, any questions on the basics of that? Hopefully it wasn't too boring. Looking at the basic kind of 13-point exam, you have to have some algorithm for how you're going to go through this. Otherwise, it's going to become kind of a mess of exam. So the first place and the place to always come back to, kind of the lighthouse of the shoulder, is the bicipital groove, okay? That's one place that today, hopefully all of you guys will be able to identify and say, yep, there's my biceps. I know where I'm at, okay? So obviously that's gonna be point number one. So what we do is we have the patient seated here. You're standing next to the patient. You have the probe transversely oriented across the front of the shoulder. So when we look on this cartoon model, we're looking across the bicipital groove in the short axis, or the transverse plane, and we're looking at the greater tuberosity, the groove, and the lesser tuberosity with the biceps right between them, okay? When you look here, here's our subscapularis, our greater tuberosity, or excuse me, our lesser tuberosity, and then our greater tuberosity, and then between them is the bicipital groove with that little tiny biceps just sitting in there, okay? Now, if you look at that, it's basically a zoomed in image of an MRI, but look how much sharper and how much more detail I see here versus that MRI. I basically have to take that MRI and zoom in to try to find all the detail that I can find by looking at that on an MRI. So that's our first point. Each point's gonna have a 90-degree opposite, okay? So the second point is also our biceps, but we're just gonna rotate that probe 90 degrees. So we were transverse to the biceps, now we're just gonna rotate it 90 degrees, and we're gonna look at the long axis of the biceps. Again, looking at that, that's now looking down this direction, up and down the bicipital groove, and you'll basically see the depth of the groove, and then you'll see parallel collagen fibers running through with a fascial layer over top, and you can see there's the fascial layer or the bicipital synovium, and then the biceps tendon runs within that layer. Okay, very straightforward. Number one, transverse. Number two, long axis. Number three is just like number one, we're just gonna slide medial. So when you're actually doing these, I would just do 1 and 3 at the same time, and then locally 5 ends up being at the same time too. I just stick it in the same position that I run right across, and I'll show you live how quickly we can do this. Basically, all you're doing is taking that same position from point 1. If you want, you can rotate the arm out a little bit, and what we're trying to do is look at the long axis of the subscap. So we're taking our view right here. The biceps tendon runs in this little blue groove right here, and we're looking at the long axis of the subscap, okay? What you see here is the lesser tuberosity, the deltoid fascia, all the tissue in between is the subscap. So that is the area that we're really trying to look at on the subscapularis. Again, it's a zoomed in version of this view, but look at all the detail I can get in that, okay? When you look at an experienced ultrasound examiner versus an MRI, they're at least as good, and usually the ultrasound is actually better, okay? Point 4, again, I said it always goes 90 degrees, so we were short axis or long axis subscap transverse. Now we're gonna turn it vertically, and we're gonna look at the short axis of the subscap, and we're basically cutting it this direction, and we're gonna be zooming in like we're looking at this piece right here, but now it's been turned around into a 90-degree version of that. So now we're looking at the humeral head, the fascia of the deltoid, the biceps groove is over here, and then we're looking at all these pinnate collagen fibers. So rather than longitudinal collagen fibers, we're seeing the axis of those collagen fibers. Point 5 is the first kind of, or no, sorry, point 5 is an extension of 1 and 3 basically. We're starting at the biceps here. We then moved over to the subscap. Now we're looking at the anterior joint line and the coracoid process. So what we see here is the humeral head. We see the subscapularis, and then the coracoid process. So point 1, point 3, and point 5 are basically all the same thing, just moving more medial and looking at that anatomy. So if you know that anatomy and it makes sense, then it's easy to see. This is another good spot where you can look at dynamic exams. You can watch the tendon move underneath the coracoid. It's an interesting look when you've never done it before. Point 6 is probably where our real money comes in. This is the first time that you're actually usually going to be finding pathology, and this is the first time you're really moving the patient. So in this exam, you're going to put the hand on the patient's hip. They're going to put their elbow back as best they can, and then you're going to parallel from their shoulder to their opposite hip, okay? And that's going to be, sorry, other way around. So you're going to go opposite shoulder to ipsilateral hip. So you're going to be looking in this direction, okay? So you're going to be paralleling in this direction because we're uncovering the supraspinatus from underneath the acromion. So we're putting it at a goofy angle by putting the hand here to get it out from underneath the acromion, and you're going to parallel contralateral shoulder to ipsilateral hip. And what we're looking at here is greater tuberosity, humeral head, deltoid fascia, and then nice linear collagen of the supraspinatus tendon. And again, it's a zoomed in version of this MRI. And this is a 1.5 Tesla good MRI. And look at the detail that you're going to see on the ultrasound versus that MRI. Okay, it's a very, very good exam finding. And again, on the cartoon version, we're looking right here. 0.7 is the one time where we're not going automatically to 90 degrees, we're just sliding backwards. This is really one point, it's a dynamic process. So I'm just sliding from the front of the supraspinatus to the back, and I'll show you this dynamically. So I haven't moved my probe, I'm just going from back to front here, scanning to look at the entire length of the supraspinatus, okay? Points 8 and 9 are also the same, but we're rotating 90 degrees now, so we're looking at the short axis, so we're rotating from the ipsilateral shoulder to the contralateral hip, and now again, it looks like that subscap view, where we're just taking the short axis of the supraspinatus tendon, so we're now coming this direction across the supraspinatus tendon. Point 9 is the same thing, just moving more posterior. Point 10 is the first time we're going to the back of the shoulder, so now we're going to do the short axis of the back of the shoulder. So basically this is almost like our biceps view, but we're doing it from the back now. And we see the greater tuberosity, humeral head, deltoid fascia, and in between is the infraspinatus. You'll notice it's a lot smaller. The subscap has the largest tendon, the supraspinatus has the next, and then infra and teres, you get smaller and smaller on their tendons. And as you go distal on this, you're going to lose all tendon altogether because you're going to get down to the muscular belly. Point 11, again, we switch 90 degrees. We're just looking at the orientation of that infraspinatus now in the short axis. And we see now the muscular tendon, or sorry, the tendinous portion. And as we get more inferior, you see the muscular portion of the infraspinatus. Point 12 is the only point where we see the joint so far, really. And what you're looking at on this cartoon view, we're looking in the back of the shoulder. We're looking at the glenoid, the labrum, the capsule here, and then the humeral head, okay? So we're looking at the infraspinatus here, humeral head, labrum, glenoid, and that's that same view as here. And when we outline it, humeral head, labrum, glenoid, and then all of this is infraspinatus, okay? And then 13 is pretty easy. It's the AC joint. You're just looking at it across the joint. You can see here the edge of the acromion, the edge of the clavicle. You can see the fascia, the CA ligaments. And then this patient has a little bit of an effusion in there, so you can see fluid within the AC joint, which is pretty common. So clinical images, this is just points 6 and 7. So basically looking at the greater tuberosity, humeral head. We have our deltoid fascia. We have relatively good looking tendon. It's not very organized, but it is intact. Right behind that, when we go back from point 6 to point 7, we're just sliding our probe backwards. You can easily see the greater tuberosity, humeral head. This is our retracted tendon tear, deltoid tuberosity, and then a big area full of fluid. This is our tear. Okay, so that's the space. In an MRI, you're usually looking at the torn tendon. In an ultrasound, you're looking at the space and the fluid that's void of the tendon. Okay, so fluid really helps you out. When you look at points 8 and 9, which are the 90-degree views of this, the short axis views, you're going to see normal tendon with a big hole here. And again, it doesn't project real well on this, but you'll see them very well on the ultrasounds. If you guys are into this and you want to learn more about it, this is a very good book. It's very straightforward and basic. The Fundamentals of Musculoskeletal Ultrasound by John Jacobson. I own this. I scan through it. If I'm going to do some new body part, I do that. Don Buford, who is not a personal friend of mine, but I've met him and learned this through him, is very good. He does courses in Vegas. There are courses in Orlando. There's courses in St. Pete and Clearwater. You can really get a lot out of doing a full course on this. And then Sonocyte has a great website, sonocyte.com. You can go in there and basically search whatever you want. They'll do a video of how to do it, and then you can get some experience doing it that way as well. All right, any questions on ultrasound? Yeah?
Do you have the bill, do you get the accredited by the AIUM or anybody else?
No, so right now there is not any accreditation requirement, okay? There is a push to try to get it, right? Orthopedic surgeons and specialists in musculoskeletal care are probably going to be exempt from that, but there is currently no requirement of that. But I don't think that it's going to be an onerous certification process if and when it does occur. You just need to show some competency, and you know, the issue is that when something makes money, people overdo it, right? So when I moved to Florida, I guess it was probably maybe 2010, where it was like just rampant. Every injection was being done under ultrasound guidance. And I think back then you got like $200 for the ultrasound, another like 50 or 70 for the injection. So it like tripled the cost of an injection. Now what they've done is they combine the ultrasound and the injection into one code. So a normal code is 20610 for an injection. 20611 is now injection with ultrasound, and it's not that much more. It's like, what, $40 more. So it almost doubles your injection CPT payment, but it's not so lucrative that they're coming after it anymore. Any other questions or anything? All right, we'll do a quick exam. Oh, was there one back there? Oh, Andrea. All All right, so you're able to hook this up, right? Okay, is it HDMI? So just to show you that it's really not that tough, I know I used a lot of words there. Yeah. Thanks for helping out. Oh, and the foot pedal, if you do a lot of these, the foot pedal is absolutely helpful. Are you able to, is there a pointer that you can point as I go? And you got some goop. So normally we're doing this standing. It's a little bit awkward. So normally the patient is just like on my exam. They're sitting on the edge of the table, and I'm standing doing it. You want to be at about the same height as the patient. You don't want to be reaching and doing all this kind of stuff. You want to be comfortable, which we'll talk about in the next talk about injections. Comfort is the key to this. So basically my right arm is going to be the probe holder during a right hand exam. And if I was on the left side, my left arm would do it. A lot of people aren't as comfortable doing that. You can do it the other way, but it's just easier because usually you have your machine here if you're messing with it. Plus you can manipulate the patient's arm with that arm. It's more difficult if you're kind of reaching this way. So I always find that whatever arm you're examining, use that arm to examine with if you can, because then this thing can, your remaining arm can move it. All right, so the first thing we're gonna do, and again, it does not project as well here. When you guys do this, it's a lot better on your machine. So the first thing we're gonna do is look at point 1. And point 1 is the biceps. Okay, so Karen's gonna show us the biceps right there. That's the bicipital groove. To the right is the lesser tuberosity and the subscapularis. Okay, to the left is our greater tuberosity. Okay, so is everybody oriented to that? Okay, point 1, super hard, right? So this is your lighthouse. When you get lost, which you will, that's okay, go straight to this and start over. All right, what tends to happen is you start moving around and you start getting lost at where your hands are, and before you know it, you're off the map. Okay, so just always go back to this position. Now the interesting thing as a shoulder surgeon for me is it's super variable where that biceps is. Some patients, I'm out here and my hand is in the same spot to find the biceps. Other patients, their arm is way across their belly to find the biceps. It is not in one spot. So I have a lot of people that tell me that they can do biceps injections without ultrasound. This is actually the one time I almost always use it because the position is so variable and patient's pain does not indicate where their biceps is. Sometimes in a thin person like Andrea here, you can feel it, but not everybody, and actually probably not most people. So point 1, short head of the biceps. Point 2, we're gonna go long axis of the biceps. So you can see the long collagen fibers there. That's the biceps tendon. If I go medial to that, you're gonna see the bone's gonna go up, that's lesser tuberosity. I'm gonna drop down into the groove, that's the biceps, and I'm gonna go lateral, and now I'm in the greater tuberosity. So see how the bone goes up, down, and then up again? That's how you know you're in the groove, and then if you see just fluid there, it's gonna be a biceps tendon tear or rupture or something to that degree. So that's points 1 and 2. Point 3 is again to the biceps, we're just gonna rotate out, and we're gonna find the subscapularis. And you can see nice linear collagen fibers there. And you can see the deltoid fascia, which is the white line above it, and then the lesser tuberosity below it. So if you see this nice area and it's filled with tissue, you've got a good looking subscap, no tear. Okay, that's point 3. Point 4, we're just rotating 90 degrees. I just rotated my hand up 90 degrees. So up is to my left and down is to the right. And I'm just looking at that same subscap tendon. It's the same as this. I'm just rotating my hand 90 degrees, and so we're not gonna see linear collagen anymore. We're gonna see dots of collagen mostly, and that's just the subscapularis. Not very helpful, but just for memory of what we're doing. Point 5 again, so we're gonna go back to point 1. Point 3 is the subscap, and then point 5 is gonna involve the coracoid as well. So now we can watch the subscap move underneath the coracoid. Some patients are diagnosed with coracoid impingement. This is a good way to see it and diagnose it, and you can inject it if you want to. So that's one good way to look at that. So that's point 5. Point 6 is the first time Andrea is going to change her position. She's going to put her hand on her hip, and she's going to tuck her elbow back best she can. Patients with a tear, this can be difficult to do. If you guys can't see, feel free to walk up here. And what we're going to do is we're going to look at that. Again, we're going to parallel the contralateral shoulder to the ipsilateral hip, okay? Because I've just taken her shoulder and I've rotated it to get it out from underneath her acromion. So you can't just put it on straight because it won't look like anything. So you want to go parallel contralateral shoulder to ipsilateral hip. So we got greater tuberosity there, humeral head to the right. The black swath right there is cartilage. That's the articular cartilage of the humeral head. The supraspinatus is above it, and then the deltoid fascia above that. So point 6 and 7 are the same points. I'm just moving. So this is the front, so this would be considered point 6. Point 7, I'm just sliding parallel to those fibers, and that's going to be point 8, okay? Oh, so anisotropy, okay? So this looks like great-looking tendon, right? Well, here, so that's great-looking tendon, right? If I change my hand just a little bit, see how it looks like there's no tendon there? That's anisotropy. So if you think you found a cuff tear, move your hand, adjust, and make sure that you see that that is not, in fact, a cuff tear, okay? And then the same thing, if you're going to look at it in the other, if you find it in one plane, you want to find it in the other plane because it has to occur in both planes. It's a three-dimensional field, right? So that's going to go from there. So 6 and 7 are basically long axis supraspinatus tendon. 8 and 9 are going to be short axis. So we're going to start medial, where the biceps tendon is, you see there. It's actually a little hard when folks are thin. So she's thin, so my probe is coming off on the medial and lateral side. So sometimes more goop is helpful, but a little bit of soft tissue is actually good for these. So we're going to go from front to back, and that's going to be points 8 and 9. And again, we're just kind of probing through and moving through, okay? And then hand back in your lap. 10 is going to be long axis of the infraspinatus. Now, in Dr. Buford's exam, he likes to stand behind and hold it. I find it easier to hold my palm on the patient's shoulder and just push it on the back of the acromion. The problem that people always run into is they want to slide down the shoulder. You don't see much down the shoulder because you run out of tendon very quickly. What I do is I hug the acromion and I actually drop my hand a little bit, and then you'll see all this infraspinatus tendon. And this is another good dynamic one. So when we move her, you can see the infraspinatus moving, okay? Now we're going to rotate that 90 degrees for point 10, no, 11 I think we're on. I always get confused at this point. And this is a little bit tougher, again, doesn't show a lot, but at the top left part of the screen, you can see a little bit of the infraspinatus tendon there, and as you go to the right, you're going to get into muscle, okay? Point 12 is going to be more medial to point 10, and now we're going to look at the humeral head on the left. So that's the ball that's moving. We can see her labrum, where the probe is, or where the pointer is. See how as we move her in external rotation, the labrum rolls back a little bit? So you can get a very nice dynamic exam on that. And then you can see the glenoid, slightly medial to that, to the right more. Yeah, just show them yeah, there you go. So that's the glenoid there. So pretty good dynamic exam. This is where I like to do my injections intra-articularly if I'm using guidance. You can obviously see where the joint stops and starts, okay? And then point 13, the last one, is the AC joint. Again, thin shoulders, so it's a little bit harder to see, but you can clearly see the clavicle on the right and the AC or the acromion on the left. Okay, so let's do it real time. So this is how long it takes in the office. So we put it on point number 1. I normally wouldn't go in this rhythm, but I will just because we're going to do it in order. Point number 2, long head biceps. Point number 3, long axis subscap. Point number 4, short axis subscap. Point number 5, coracoid. Point number 6, hand on your hip. Anterior supra. Point number 7, posterior supra. Point number 8, short axis supra. There's our biceps right there. We're going to move posteriorly to point number 9. You can see a little bit of fluid in one little spot there on our supra, right there. That's probably real. You've read about this? All right, hand back in your lap. Point number 10, posterior infra long axis. And again, one nice thing, touch your other shoulder, your right hand. You can really kind of uncover the long length of the infraspinatus by doing that. Okay, point number 11, hand back down. Short axis infra. 12 is the posterior joint line. And then 13 is the AC joint. And that's actually longer than usual, because usually I'm only doing a few of those points, so you don't have to do all 13. But as long as you document, thank you, Andrea. As long as you've documented that you've looked at a bony, a soft tissue structure, then you can bill a comprehensive ultrasound exam. Questions on diagnostic ultrasound? Is that pretty straightforward? No? All right. You'll get a chance to play on each other shortly. All right, so we'll go back to mine. Ask questions, we got time. What time is it? Oh, we're good. We're good. All right, how many of you guys do injections of the shoulder? So a handful. How many of you guys want to do injections of the shoulder but don't feel confident? Okay. So ask us as we go around today. I'll give you my thoughts on it. This is Dr. Baker's opinion on everything. Okay, this is not medically or what's the word? It's not. It's like I didn't do a medical search on this. This is just how I do it. I think it's easier to explain that way. Dr. Gasser has his way. Dr. Yee has his way. We all do tons of shots. I mean, I would say probably 40% of my patients every day get a shot. It seems, if they're of age. Obviously, I don't do this in a lot of athletes that I'm trying to get back into sports or anything. This is usually people with overuse injuries and tendinopathies that we're giving these shots to. So we'll do ultrasound guided shots first, and then we'll follow that with what I call blind injections, and kind of the principles and pearls of that. All right. Oop, gotta turn it on.